So now we're going to move on to the negative consequences of screening. The intended learning outcomes for this module include the ability to identify concerns of women regarding mammogram recommendations, the ability to use your understanding of the data and consensus opinions to support screening recommendations, and the ability to reassure patients regarding mammogram radiation and other concerns. The negative consequences of screening include a patient being recalled from screening mammography for extra imaging, false positive mammogram results leading to biopsy, overdiagnosis, radiation, and anxiety or patient discomfort. A patient being recalled from screening means that additional mammographic views or an ultrasound have been recommended. The benchmark for the occurrence of screening recalls is that it should occur less than 10% of the time, but somewhere between 5 and 10% of all screening mammograms will be recalled for additional imaging. This is going to be slightly higher for women who are having their first or baseline mammogram study, and the risk of being recalled from a screening mammogram decreases once more screening has been performed and old films are available for comparison. So being recalled from screening does produce some anxiety for patients, but that is usually resolved once they've come for their additional imaging, and approximately 90% of the time those recalls are going to lead to a normal result on their mammogram. False positive mammogram results occur when a biopsy is recommended from a mammogram study and a benign diagnosis results from the biopsy. The benchmark for this entity is a positive predictive value of a recommendation for biopsy in the range of 25 to 40%, or approximately 30% of the cases which we recommend for biopsy will turn out to be cancer. An analysis of the USPSTF CISNET computerized data with regards to false positive biopsy data showed that for every 1,000 screens per year, approximately 4.3 to 6.7 will result in a false positive biopsy result, which corresponds to once in 149 to 233 years of screening will occur for a woman who gets screened between her 40s and 70s before she has a false positive biopsy result. So although this does occur, it is very rare for any person to undergo a screening mammography program for their lifetime and have a false positive biopsy performed. Overdiagnosis is considered another part of the negative consequences of screening mammography for breast cancer. Overdiagnosis is the detection of a breast cancer at screening that would not have been identified clinically in a woman's lifetime. This is a controversial issue. It has been reported anywhere from 0 to 31% of cancers diagnosed are overdiagnosed, meaning they would not have become apparent in a woman's lifetime. This assumes the ability to discriminate a good cancer from a bad cancer on imaging. The diagnosis is typically made at the time of imaging, and we at this time cannot discriminate on mammography or ultrasound which is a good cancer and will not bother the patient and not be an issue with her clinically in her lifetime versus a bad cancer which will go on to limit her lifespan. A United Kingdom review of overdiagnosis of the randomized controlled trials demonstrated a 10.7% overdiagnosis rate in the studies that were performed as part of the randomized controlled trials that did address overdiagnosis. This is a number, the approximately 10% rate of overdiagnosis is what seems to be coming out of the majority of the literature as the accepted number for the rate of overdiagnosis related to screening. In a meta-analysis of observational studies from the European populations was published in 2012, and this review of the observational studies demonstrated anywhere from 0 to 10% overdiagnosis of cancers for women who had their data in this study was controlled for both breast cancer risk as well as lead time bias, and women where the studies controlled for the breast cancer risk and lead time had overdiagnosis in the range of 0 to 10%, with a significantly different outcome for studies that did not control for breast cancer risk and lead time. And this seems to be contributing to the analyses that report the higher ranges of overdiagnosis for cancer detection and screening mammography. So it's important to analyze the studies closely to determine what controls they're putting on the data. Radiation is a concern of patients related to mammographic imaging as well as all medical imaging. Screening mammogram exam is reported to have approximately 0.4 millisieverts of radiation dose to the patient, which is a very small dose. The background that people get in the United States is on average about 3 to 4 millisieverts per year. And the dose from the screening mammogram is equivalent to about 1 to 2 months of the ambient exposure that we all receive just in our normal states. There's no direct evidence of increased incidence of cancer related to the low-dose radiation that women receive in screening age of 40 and above. The breasts are more radiosensitive in the younger years, and it's considered that after age 40 that this radiosensitivity significantly declines and the breasts are less radiosensitive at that time. A policy statement from the American Association of Physicists in Medicine in 2011 reported that the risks of medical imaging at effective doses below 50 millisieverts for single procedures or 100 millisieverts for multiple procedures over short periods of time are too low to be detectable and may be non-existent. This should help to reassure patients that the doses required for screening mammography, which is very low dose, are acceptable for diagnostic purposes. Anxiety and false positive screening mammograms was addressed in a study that was a sub-study of the DMIST, the Digital Mammography Imaging Screening Trial, that was reported in 2005 initially. This was reported in 2014. Anxiety is a difficult area to study. It's a very personal issue, but this study addressed women who were recalled from screening, and they had phone interviews at time 0 at the time of their recalls, as well as at 1 year with a validated anxiety scale. And this study showed that there was an increase in short-term anxiety related to their recall from screening. However, there was no significant increase in their long-term anxiety related to their imaging recall. Interestingly, the fact of getting recalled from screening did increase a woman's future intention to be screened. So they were more likely to come back in the future if they had been recalled from screening. So in addition to the harms of screening that we've discussed, or the proposed harms of screening, it's important to also remember that there are harms of not screening. The harms of omission if screening is not performed. And those include underdiagnosis or death from advanced cancer, increased morbidity related to the need for more aggressive surgical treatment or chemotherapy, the false positives of physical examination and palpation-guided biopsy, the costs, including both financial cost as well as human costs of women who are diagnosed later in their disease and have a significant morbidity, and the lack of identification and treatment of pre-invasive breast cancer. So this is important to keep in mind when counseling patients as well regarding screening mammography. The Michigan Cancer Consortium screening guidelines, as I just described earlier, were released in 2014 and include recommendations for both women at average risk for breast cancer as well as for high risk for breast cancer. The screening recommendations for imaging for women at average risk for breast cancer are to start annual screening mammography at the age of 40 and continuing yearly as long as the woman is in good health. There are also recommendations in this guideline, which is available as a web link on the CME website for breast awareness as well as clinical breast examinations. For women at high risk for breast cancer, which are listed on the left, the risk factors here, with the greatest risk factors including known genetic predisposition, including BRCA gene mutations, women at high risk for breast cancer based on lifetime risk models, and prior exposure to thoracic radiation between the age of 10 and 30. Those women are at significantly increased risk for breast cancer, and the recommendation is for screening annual mammography if they have the genetic predisposition beginning at age 30, with MRI annually beginning at age 25. Women who are at high risk for breast cancer and prior thoracic radiation similarly are recommended to have both annual screening mammography as well as annual MRI beginning at age 30, or in the case of radiation, beginning 8 years after radiation has been finished. Women at intermediate risk of breast cancer, women who have a personal history of breast cancer, a risk in the 15 to 20% range for lifetime risk based on risk models, as well as personal history of breast cancer or atypia or LCIS. Those women are recommended to have screening annually starting at age 40 with risk assessment, more formal risk assessment if they have multiple risk factors to determine if additional screening would be indicated with MRI or ultrasound. So in summary, the randomized controlled trials, observational studies, and computer models show mortality reduction with screening mammography beginning at age 40. The largest benefit has been shown to come from annual screening beginning at age 40. The controversies regarding the age to start, however, the age to end, and the frequency of mammography remain subjective judgments on the relative value of the benefits and harms of screening. The MCC guidelines for screening, imaging, and clinical examination in women at high risk and average risk for breast cancer is available on the CME website with a web link for your use in the future.